Hi, and welcome back, everybody, to This Emergency Life, where we learn to take the chaos of the ED and we bring clarity, learning, and purpose. I'm Kevin, and today's case might be familiar to many of us. It's an upper GI bleed, but not just any GI bleed. This one comes with a side of liver disease, instability, and the unforgettable scent of crisis. This is esophageal varices. Let's set the stage. You're assigned to the ED's resuscitation area for the day. It's 7:26 a.m. on a Tuesday morning. Charge nurse is settling the board. The resus bay is, all right, I'm about to say it, quiet, too quiet. And as soon as that thought passes through your mind, the red phone rings. The EMS dispatcher alerts you to be advised ALS unit is en route, ETA 6 minutes, with a 54-year-old male with a known history of alcohol abuse, vomiting large amounts of bright red blood. He's hypotensive, infused. His GCS is only 12. He's 76/42, heart rate 122, and 92% on non-rebreather. 2 large bores with normal saline wide open, and they're requesting respiratory at the bedside. So it's time to mobilize. A call like this should activate an all-hands response in your mind. So let's talk through this setup. You find the doc that's going to be handling this case, and you relay all the information you just got from the EMS dispatcher. The doc is like, this is likely variceal bleeding. We're going to need a resuscitation bay cleared, suction set up, oxygen ready, 2 high-volume Yankauers, advanced airway equipment to the bedside, and maybe even a bougie and an 11 blade, if you know where. We need to prep and prime the rapid transfuser. We're going to call blood bank for 6 units packed red cells, 6 of plasma, maybe a pack of platelets, warmed now. Someone should prep airway RSI meds like etomidate and Sux. We're going to grab octreotide, Protonix, ceftriaxone. And when you have the luxury, advance notice of impending arrival of a patient like this, and the opportunity to prepare those types of things before, it makes for a smooth resuscitation. So let's pause for 1 second. An unstable GI bleed. Differential diagnosis includes esophageal varices, think liver disease and alcoholism, peptic ulcer disease, especially with people that abuse NSAIDs or have a history of H. pylori, Mallory-Weiss tears, people that have been forcefully vomiting, or things that are rare like aortic fistula from like post-aortic surgery. But this patient, he has cirrhosis written all over him, spider angiomas, caput medusae, and a history that we know all too well. He arrives to the ED. He's altered, continuously vomiting blood. Blood pressure is tanking despite fluids. EMS gave 1 liter of NS so far. We get him on the monitor. We do a new full set of vital signs. We're going to secure the airway in this case. We make sure the suction's ready, and we start bagging this patient very gently. We're aiming for first pass success with direct laryngoscopy. Intubation, successful. 2 large bores are already running. We're going to push octreotide 50 micrograms bolus, and as soon as we're done, we're going to set up a 50 mics per hour drip, followed by a Protonix 80 milligrams, and then an 8 milligram per hour drip, and also give 1 gram of ceftriaxone. In cirrhotics, this can save lives. We want to call GI. We know this is variceal. This is where knowledge meets performance, and the suspected esophageal varices, your evidence-based toolkit includes octreotide, which reduces portal pressure and bleeding, your Protonix, which is a proton pump inhibitor, which is going to help stabilize any clots, and ceftriaxone, which we don't always think about in cases like this, but shows a true mortality benefit in cirrhotics due to potentially of an infection risk. Massive transfusion protocol may be in order. We're going to do a 1-to-1-to-1 with warmed products, and reversal of anticoagulants such as with vitamin K or PCC might be necessary. NG tube or OG tubes are controversial in some patients and may induce vomiting, but in cases like this where they've already been intubated, it's probably a good idea to go ahead and get their stomach emptied. As a last resort, we may be using a balloon tamponade device, such as a Minnesota, a Blakemore, or a Linton tube. This requires sedation, airway. These devices in your hospitals, you need to know where they're stocked if not already in the emergency department. The patient's now sedated, intubated, and off to ICU. GI will be scoping him shortly. He'll likely need banding, repeat transfusions, maybe even a TIPS procedure, a transjugular intrahepatic portosystemic shunt, sometime down the line. So this case, it's a reminder. Upper GI bleeding in a cirrhotic patient is not just a GI problem. It's an airway problem, a perfusion problem, a team-based resuscitation challenge. And when it's suspected as variceal in nature, you don't wait. You don't hesitate. You act. So the next time that EMS call comes in, remember, what walks in the door might be vomiting blood, but underneath, that is a fragile physiology, possibly one misstep away from an arrest. Prep your team, know your resources, and lean into the guidelines because complacency in these cases can kill. This has been This Emergency Life. If you enjoy this content, please subscribe and share with your team. And remember, every code, every shift, every patient, it's all about preparation, performance, and passion. Stay sharp, stay ready. I'll see you on your next shift.